See, this is being broadcast on YouTube when it goes live, so we don't know how
we
many
are now
people are
live.
recording it. Welcome. This is the third meeting of the Mental Health, Healthcare and Overview Scrutiny Panel. We have three witnesses tonight. This is a public meeting and is being broadcast, so just some housekeeping. Please turn off your microphone and video and only turn them on if you're going to speak. Jen, our officer, may put everyone on mute if there is feedback or background noise, so remember to unmute yourself if you need to. Please remember to raise your hand via Zoom if you'd like to contribute. Don't forget to unmute and use camera. Please say your name before you start speaking. Our first guest, or witness as we call him, is Ansa Khan, who's the team lead, Friends in Need. And I've just got to take apologies. Jen, do we have any apologies?
We've received apologies from Councillor Brossard, Councillor Mrs Mackenzie and Councillor Atkinson.
Thank you very much. Declarations of interest. I don't see any hands being raised, so I'm going to take that as there are any. Welcome, Ansa, and thank you for taking part in this review. We're hoping for about a 10-minute presentation, and then we've got about 15 minutes for questions. So if I can just ask the members to introduce themselves. Can I start off with Jill? Jill, are you there?
Yeah, I am here.
Thank you.
Apologies. I was just doing something else. Jill Birch, councillor for Hanworth. I represent on the borough, and I'm a Bracknell Town Council for Birch Hill.
Thank you very much. Lizzie?
Thank you, Chair. Councillor Lizzie Gibson, Great Holland South.
Isabel, my Vice Chair.
Thank you. I'm Isabel Mattick. Good evening. I'm a councillor for Harmonswater. Thank you.
Nick?
Nick Allen, I'm councillor for College Town.
Ankur?
Thank you, Chair. Ankur Shiv Bhandari, councillor for Binfield with Warfield.
And Jen?
Jen Lawson, I'm the Governance and Scrutiny Officer supporting this review.
So, Ansa, over to you for your presentation, please.
Right. Okay. Thank you. Hi, everyone. I'm Ansa Khan. I'm the team lead for Friends in Need. We're a part of a service that Buckinghamshire Mind provides across East Berkshire and Buckinghamshire. I'll give you a brief overview of what we do and how we do it. So essentially, we're a peer support service, and we work in East Berkshire across Windsor, Ascot, Maidenhead, Bracknell and Slough. And in Buckinghamshire, we're in the south and the north of the county. And essentially, we provide a whole range of wellbeing activities for anybody affected by mild to moderate depression, social isolation, and anxiety. We do this by running a whole range of activities across our network, which promote resilience, empowerment, and wellbeing to a whole host of people across the county. Let me give you an example. So what we do every month is we produce a timetable. We have coordinators across each area, and we produce a timetable of events and activities which are primarily volunteer-led, but are also run by some of our coordinators. And we do lovely things such as well-being physical activities such as yoga, tai chi. We do meditation. We do things like arts and crafts. We do well-being activities such as singing and laughter therapy. We have quizzes. We have, the list is endless. We have over 100 activities a month. And how we do this is by including and involving our volunteers in all of our activities and engaging members of the service to feel inclusive and to promote a sense of ownership, I think. Through the pandemic, let me give you an example. So prior to the pandemic, we were doing all our activities face-to-face. We had to pretty quickly, almost overnight, develop a whole range of services that we could do online. So we did this by consulting with our members and our volunteers, and we were able throughout the pandemic to provide ongoing support to people virtually. We did this via Zoom, via Facebook Live, and via Teams. And we found that probably that was our busiest time, as you can probably imagine or understand. And we've continued to develop those online services. But since we've gone back to more face-to-face activities, we now provide a more blended service. So some of our activities are face-to-face, some of them are online, which gives people the opportunity or the choice if they want to use both elements of our service. Referrals we get from a whole variety of referrers, for example, GPs, talking therapies, the social prescribers, the wellbeing services, and self-referrals. So we can take referrals from most organizations. The beauty of Friends in Need is it's very much service-led, service user-led, and we make sure that we involve and include our members and our volunteers in what we do. And that's the sort of overview of the service. I'm happy to take questions from you if you feel that you need to find out a little bit more. I've just given you our service in a nutshell, and I'm happy to discuss it further with anybody who wants to ask me questions along the lines of how we provide our services. Mike.
Anza, thank you very much for that.
That was just a little nutshell. I was just giving.
That's fine, because we've got some questions that we'd like to ask. We might look into that a little bit, into certain areas more. So the first question we're having is from Councillor Lizzie Gibson.
Hi, Ansa.
Hi, Lizzie. How are you today?
I'm very well, thank you. My question is, do you have any statutory or service level agreement responsibilities for mental health care?
Yes, we do. So our funding comes from the CCG at Frimley, and we have key performance indicators that we have to meet every quarter. And based on those, we maintain robust statistics of attendance, attendance, what activities are attended by whom, whether it's online, whether it's face-to-face. And based on those KPIs, I have to produce a report every quarter to make sure that we are meeting our obligations to our funders.
Could I ask a quick follow-up? Are any of those KPIs related to the referrals process and access to care?
Yes, they are. We have to indicate where the referrals come from. We have to indicate, obviously, how many referrals we get from each service area. So yes, we are answerable to that requirement as well.
And could I just ask I apologise if you don't have this sort of information, but what's your feeling of where the majority of those referrals are coming from?
I would say it's a bit of a mix at the moment. I would say probably the least of our referrals come from GPs. We have the social prescribing teams are fantastic in referring to us. The wellbeing service, talking therapies, I would say self-referrals are we get a lot of self-referrals as well, because we do a lot of promotion within the community. Our volunteers and our members are almost our ambassadors for the service. So self-referrals are quite frequent as well.
Thank you. That's really great to hear.
You're welcome.
Thank you very much for that. I shall go around our list of questions. Nick, could you?
Yes, hi, sir.
Hi, Nick.
Right, so let me just find the question. So,
excuse me.
How many people are you supporting now,
Okay,
compared pre-COVID?
That's a really good question. I would say we have increased our membership by at least 25%. across from the start of COVID, prior COVID, and now. We found during the first 3 months of lockdown, our referrals went through the roof, which is probably understandable. We had an influx of new members. We had an influx of interest in our activities, and that has kind of sustained itself, I would say, throughout the whole of the last 18 months, certainly.
Okay, so how has your service changed as a result of the pandemic?
So previously, pre-pandemic, everything we did was face-to-face. So we have certain venues we use community halls, we use local coffee shops, we use certain venues. For example, in Windsor, we use one of the All Saints. There's a church called All Saints. In Hampstead, we're using some of their venues. I would say that the way that it's changed is that we have now been able to provide a blended service. The online accessibility and for people to want to use our services online is the biggest difference, I would say. And what we're going to do and are continuing to do at Bucks Mine Friends in Need is to offer a blended service. So we'll have the face-to-face activities, but we'll also provide the online services via Zoom. So our timetable now reflects this in that we have an online activities timetable and a face-to-face activity. And people have that choice now that they can access either or both. We don't say that you can't have one or the other. Everyone is able to access all our services across the whole network, whether it's Bracknell, Windsor, Ascot, Maidenhead, and Slough across East Berkshire and also in Bucks.
Does that sort of give you more capacity, do you think?
Oh, most definitely, most definitely. We have found that, for example, if we're running an online group, people right across our network, not just prior to COVID, only people in that particular area. For example, if we're running an activity in Bracknell, they could only go to Bracknell to access that activity. Now, because it's right across the network and it's online, we have people from all service areas able to access services. So yeah, it's increased our capacity considerably.
Thank you. Mike.
Thank you, Nick. Isabel, if you'd like to continue.
Sorry, my fingers aren't feeling very well. Thank you very much for that. Can you tell me where your referrals come from, please?
Yes, yeah, our referrals come from a whole range of referral pathways. So we have referrals from GPs, the social prescribing teams, the wellbeing service, from talking therapies, from health makers, self-referrals. In fact, we will take referrals from most statutory and voluntary organisations. What I would like to add, which I didn't add, I don't know whether that's relevant to your question, Isabel, but we have three sort of cohorts of services within Friends in Need. And one is the general fin, which anybody can access, mild to moderate depression. Within the last 6 months or so, we also launched two other services. One is for young adults within East Berkshire, and one is for people with more significant mental illness. So the young adults is for the 70 to 25-year-old age group, and that is, again, self-referral and any other organisation within the East Berks network. And then for the more significant mental illness, we take referrals from the community mental health teams, from talking therapies, from GPs, and from the recovery colleges. So that kind of gives you a broad overview of where all our referrals come from for all our groups.
And I appreciate you've got a wide range, but are there any which you feel then that an area where they're not coming from at all? So
I would say that probably the sort of ethnic minority groups, I would say, referrals are, I would say that they are the least referred.
Yes.
Yeah.
So that's a shortfall.
That, yeah, there are various reasons for that, as we probably.
Yes, of course.
But yeah, those are the areas that which we are promoting more into and trying to make our services more accessible, more aware, and so people feel more comfortable being referred into us.
Yes, fine. Thank you very much for that. Thank you.
That's very helpful. Jill.
Thank you. Thank you for that. It's a really interesting answer. Thank you very much.
You're welcome.
My question is, regarding the system, what do you think helps customers to access your service?
Oh gosh, that's a very good question. I would say of the service, the ability to make it easy for people to access us. So the way that we do it is that people are referred to me, and then I will refer people onto the different sort of service areas that we have to the relevant coordinators. I think the barriers are, as always, stigma, lack of awareness. I think also promotion is something that we do really well to make people aware of where we are, who we are, what we do, and how we do it. So I think it's a whole host of things that go into making us accessible and making people aware of who we are and what we do.
So do most of your referrals come, the ones that are self-referrals, come through the internet, access through your website? Or
it can be through our website, it can be through word of mouth. We have found that word of mouth for within existing members is a good way to attract new membership. People talk to each other. I think they realize who we are, they understand who we are. I think the website is also a very good way. We have also every month when we do the timetable, I send out an email to all our area partners, for example, every organization that we work with. We'll send out updates. I'll send out our referral process. I'll let them know how we do it. They're aware of the scope of reference that we have, and they're aware that, what the pathways are that they can refer into.
That's very interesting. So you've mentioned barriers. So obviously, if you've got this gap, ethnic minorities, what barriers are holding those people back from coming forward for help?
I think language is often an issue, I would say. Communities, I find, tend to sort of contain themselves within their own communities. So I think accessibility outside of their community would be a good way in. Language, stigma, people not being aware of services, I think, is another barrier. But I think possibly cultural barriers as well, and understanding of each other's cultures, I find, would be a very good way to make people more aware of our services.
That's very clear. Thank you very much. Yeah, I'm very interested how you promote. You say you promote by word of mouth. Do you actually put sort of pop-up posters, or what do you do, and how?
We'll do a whole raft of things. We'll attend networking meetings. We'll do leaflet drops. We'll go to GP surgeries. Next week, I'm going to one of the local mosques.
Oh yeah. Yeah,
to talk to some of their people that attend their congregations, to let them know about our services and to make them aware. So that's we are very visible as we are very well established in the area, so people tend to know about Friends in Need. And we also like to be a part of networking events. We did, where I met Mike actually recently, we did a promotional event for World Mental Health Day, for example, at South, where we had a stand, and we had our leaflets, and we let people know how to access our services. So we make ourselves very visible and very accessible.
So do you have leaflets in libraries?
Yes, we do. Yeah, we do leaflet drops. We often, every 6 months or so, we like to do leaflet drops in various, for example, community boards at supermarkets. Coffee shops often have community boards. Other various community venues, churches. So we are in touch with a lot of the local organizations to inform them of our services and how we have developed, certainly during the pandemic and prior to that as well.
Thank you very much. That's really, really interesting. Thank you.
Thank you very much for that. Jill, as always, grateful for your presence. Jill chairs the other overview and scrutiny panel, one of the other panels, so it's always good to actually see her come along. Anchor, if you'd like to come in.
Thank you, Mike. Hi,
Hi.
hi there. I really liked, the terminology you used of referral pathways, and that the referrals first come to you and then you assign them to the relevant people.
Yes.
So is there a effectiveness measurement mechanism that you have?
When you say effectiveness, what do you mean?
So how do you measure effectiveness? What are the KPIs? You did talk about KPIs
Yes.
earlier.
Okay. So we consult with we have feedback forms which go out to all our members every 6 months. We like to measure the effectiveness of our services, the satisfaction levels of our members, and how we can build on those and try and improve, change, or develop our services. So we are always very much inclusive, and we consult with our members on a regular basis. We have regular volunteer meetings where we have representatives from each service area. We consult with them about service development, and that is evident in in our KPIs going forward, how we include our service users. So feedback forms, service user involvement, and volunteer involvement. We have, I would say, across our network within Friends in Need, around 40 volunteers, and they are very much included in the developing of our services.
Very good. So these, the KPIs that you talk about, are they both quantitative and qualitative?
Qualitative.
Or
I would say they are pretty much both. They are largely qualitative, but the feedback services, they are quantitative, but the feedback is qualitative. So we use both as a measure of how we can develop our services and how we are doing with the services we have and how we can develop them going forward. Does that make sense?
Yeah, absolutely.
Yeah,
very good. Thank you so much. A slightly related question, but so what helps you ensure that your customers stay engaged with your provisions?
In my experience, in my opinion, the best way to engage people is for them to have a sense of ownership of service and inclusivity, that they have a say in how the service is developed, and the activities and the services that we provide include their opinions and take on board. I think it's to do with respect and inclusivity. We are very much an inclusive service.
Brilliant. Yeah, thank you so much. Over to you, Mike.
Following on from the last comment there, Lizzie's got a follow-up question. So,
sure.
Lizzie.
Thank you, Chair. Really good to hear the importance of inclusion for you.
Absolutely, yeah.
Do you find you're getting many neurodivergent residents get involved, such as autistic people and people with other disabilities?
Yes, I mean, we openly. Sorry, go on. The question.
How do you meet their particular needs?
We encourage people right across the spectrum. Obviously, we have a scope which we have to work within, and in terms of people with learning disabilities and autism, because it's peer support, we encourage, or we have to remain within our scope. So we have to work within sort of high functioning learning disabilities and autism. Although we'd like to be right across the spectrum, we don't have the facilities or the qualifications to deal with people with more complex needs. So it has to be, we have to be mindful that they're the right service, that we are the right service for them. We can do justice to their needs as well. So if people fall within the scope of our referrals, we're happy to take them on. Otherwise, you have to signpost them on. Does that answer the question?
I think it does, because you just signed off.
Okay.
I see another member of the panel has joined us. So I'm just asking, Mary, did you have any questions you wanted to ask?
No, everything's been asked, thank you, and answered.
Thank you, Mary. I just wanted to make sure you weren't being
No, I only caught the end of this. I do apologise for being late, but I did.
No problem. Happens to all
I'm
of
here
us,
now.
Mary.
All right, so
It
thank
happens to
you.
all of us. It's not a problem. You've touched on these earlier, but just sort of coming to the end of the questions, if anybody has any follow-ups, please do either indicate to me because we do have a good 5 or 6 minutes left. Challenges in keeping the customers engaged. What challenges do you think specific to COVID have been in making sure people follow up services? And is there anything else that you think we should know about access and engagement to your service?
I mean, COVID brought so many challenges, as we're all aware, and I think that we rose to the challenge, I think, at Friends in Need, and we were able to provide and continue to provide optimum services to all our members. The challenges we face, I think COVID affected so many people in so many different ways, and to be aware of where people are in their mental health. Some people relished, or rather really welcomed, the online services. Other people found it very difficult because they didn't, tech was difficult to access. We provided online training for our members. We had somebody at Bucksmine that would help people get onto the get onto some of the tech, some of the online sessions that we had. But challenges, I think, are always funding is always, we always need more funding. Yeah, that great challenge that we all need. We would like to grow and we would like to expand our services, but we are confined, obviously, by the funding that we have. We have expanded quite considerably, I would say. But as always, I think funding is a challenge. Engaging service users, keeping service users is a challenge, depending on where they are in their own mental health journey. I think that's been a big challenge during COVID.
That's been very helpful, Answer. You were mentioning a report you had earlier. Would that be possible to send to Jen so she can distribute it to the panel members?
You mean the report for the CCG?
Yeah. Is that?
Can I just ask my line manager?
Yes, of course. Yes, of course.
God,
Send that with Jen, and if possible, that'd be great.
Yeah.
If not, we understand.
Yeah, I produce a quarterly report.
Yeah.
So yeah, I just finished one in September, actually. So that's the latest one, which gives an overview of the service, area updates, talks. It shows our.
If it's allowed.
Yeah, all of that.
I think it might be interesting. You just liaise with Jen on that. That would be excellent.
Let me just check if I can do that,
Of
and
course.
if I can, I'll be more than happy to do that.
We hope that we will come to our sort of draft recommendations and finish our report by early February.
Okay.
And obviously we'll send you a link to that, so you've got
Great.
what will come out for that. I do have Jill coming in with an additional
Cool.
question, if that's okay. So Jill, we do have a few minutes left, so that's good.
I'm going to put this in a real simplistic way, but do you have any success stories? Do you have any sort of case stories, cases that you could actually say, well, actually, I feel that for this particular person or this person, we really success?
Gosh, I'd like to say we have a whole host of success stories.
Excellent.
Absolutely, a whole host of success stories. And I did speak with Jen actually about this yesterday. I think we spoke, and I think there might be somebody that we can actually involve, one of our service users that would be happy to possibly talk about his experience at Friends in Need. I mean, I many people spring to mind, but I think it'd be really nice if you had somebody talk.
Perfect.
His experiences. So I am trying to organize that. So maybe Jen could talk about that, possibly. Jen, what do you think?
Yes, absolutely.
Would that be okay?
Yep, I will. I'll catch up with you, Answer, about how we make that happen.
Yeah, I mean, just to give you an example, Jill, last year during COVID, one of our service users had to go to hospital for various health reasons. And because of our online, she was able to access the groups that we were running via Zoom. And she said that really helped her while she was in hospital.
Well, that's really positive.
It actually boosted her morale. It made her feel better. She could see her friends online.
Oh, so lovely.
Real life stories that we kind of touch every day. People that say, Friends in Need saved my life. I would not have been able to see my friends had it not been for the Zoom activities, or had it not been for some of our face-to-face activities. We started off by really simple things in August last year when lockdown came. That it was by walks, small groups walking for an hour. Obviously, social distancing, maintaining the track and trace. But that in itself was a godsend after months and months in isolation. So we've got some lovely, lovely stories and little testaments and quotes
Oh, lovely.
that we have within the report that I do every quarter, that we send to our funders, say these are some of the real life lives that we've touched during the course of our services, and of course during the pandemic.
So one of those, your last quarter, if you can share that with us, that would be fabulous. Because
I will absolutely. Let me check with my line manager to make sure it's appropriate. So yeah, if that's all right.
What do you think is your favourite activity that people appreciate the most?
I would say we have a fantastic art group which runs locally. Well, there's one in Windsor and there's also one in Bracknell, which I feel we have normally attendance of 15 to 20 people on a Monday. But I would also say that the online meditation that our volunteer does with gongs and sounds and things on a Tuesday night has been absolutely amazing. She's done that for 18 months for the lockdown period via Facebook Live religiously every single Tuesday. So that's another really, really popular. We have a fantastic quiz night. We do singing on a Wednesday. We've done it via Zoom for the last 18 months. We're now going back to face. So there's lots of lovely little stories and lovely little anecdotes that I could tell you, but maybe I can demonstrate that in the report.
Thank you very much. That's
welcome.
Nice to hear. Thank you.
You're welcome.
Thank you very much for that answer. I'm so glad we ran into you. I think that's
yeah, I hope that helped.
Oh yeah, very much so. Very much so. And if we've got any follow-up questions,
absolutely,
we'll do them through Jen.
More than happy
to organise that.
Okay. Can I go and get my dinner now?
Now you can go and get your dinner. Thank you very much for your time.
Thank you very much. Pleasure to meet you all. Take care.
Thank you.
I know.
Thank you. We're very jealous we haven't had our dinner.
Yeah. Bye.
Right. So we're still streaming live. Is Jen, do we have
yes, Bernadette Fisher. She is waiting in the
before
waiting
we go
room.
into that, one of the questions that I'm asking is, what challenges do you face in keeping customers engaged? Actually, there is one. What do you meet community? Mary, would you like one of these questions to ask?
Yeah, tell me what it is and then I can write it down.
I can pop it in the chat if you'd like, Mike. You were asking 13 and 14. If you tell me which one, I'll pop it in the chat.
I was going to say 10.
Okay.
And what do you mean community needs to do like this? High level services, and 13.
10 and 13. Okay, I'll pop those in the chat for you, Mary.
Okay, brilliant. I'm on that now.
Okay, I'll just we'll get Bernadette started and then I'll send that to you.
So I'm going to so you'll be following Jill, because I'm going to stick to the order that we're asking questions, because as Nick Allen has very helpfully pointed out, there is a sort of natural flow there. So I will put you on after Jill and before Anchor. So we've got our list, and I'll send you a reminder while we're doing it. So if we can have Bernadette, please.
Okay.
Mike, I was supposed to be asking 1 and 2 on this one.
It's 1 and 2 for the third witness.
Was it? Witness, not
yes.
for the second.
Yeah, with the same format for this witness.
So we'll deal with that after we've spoken to Bernadette, and then we'll make sure that we've got something for under the questions for Katie.
Okay, Bernadette's just joining us now.
Hello, Bernadette. Just making sure that we can see and hear you. Hello, Bernadette. Welcome to the Overview and Scrutiny review of mental health. It's an absolute pleasure to invite you along, and I'm so glad that you did. If you'll give us your presentation, and then for about 10 minutes, and then we will go through asking questions from the various members of the panel, if that's okay. You're on mute, by the way.
Hi there, yes. Sorry, I didn't prepare a presentation as such. Jen just said I'd be here to talk and answer questions, but very happy to talk about the Recovery College.
I use the phrase presentation lightly. It's just if you sort of introduce you and what you do,
sure.
About a few minutes, and then we'll come in with the questions. That's
Please
fine.
do. Yeah. Okay. So, well, hello, good evening, everyone, and thank you for inviting me along. I hope everybody received the midterm report, have they? Can I just check, because I might allude to that.
I'm not having anybody say that they haven't had it. So
okay, that's great. Okay, just to give you a bit of context, so I'll give you a bit of background, because the report, as you would have seen, focused on really kind of what's happened since we launched. But I'm not sure how many of the committee know about recovery colleges generally. I mean, they have been around since about 2009, and there are over 90 now in the UK. And you probably know there's one in Reading that's actually been around for about 15 years, and a new recovery college was set up in Wokingham about 18 months ago. And they're all, the model is the same, but they operate slightly differently. So quite a few recovery colleges operate within statutory services, usually statutory mental health services. Some, like Stepping Stones, are set up as independent charities. So I set up Stepping Stones as a charitable incorporated organisation in 2020. And so we operate independently, but very much in partnership and supporting other statutory and voluntary bodies as well. The funding we receive is partly from local public health funding and from private grants. So recovery colleges really, in essence, operate on the basis that recovery from, whether it's a diagnosed mental health condition or even it isn't simply mental health that we're focusing on here, we're focusing on people who are struggling because they might have had something physically, a long-term, they might have had a long-term condition that's made them feel quite separate from mainstream life. Particularly post-COVID, there are a lot of people, as you know, who are under the radar, who aren't perhaps diagnosed, aren't engaged with any services, who are still struggling with anxiety, even PTSD, and conditions like that. So recovery colleges and Stepping Stones has a really broad remit. So we are there, we're open and available and offer free workshops and courses to anyone in the borough over the age of 18. We operate on the basis of self-referral, and also we're pretty well diagnosed as blind in the sense that we don't ask people to divulge, unless they want to, what it is or why it is that they've come to us. So we found that a lot of people do want to talk about that, but that is not a prerequisite. We do ask them to fill in an equality monitoring form, and on that they can disclose if they wish, but there's no requirement to do so. So the way we operate, which is very much the model of other recovery colleges, is firstly that the ethos is that once people have got to a certain point in their recovery, whether that is from in addiction recovery from a diagnosed mental health condition or another kind of trauma, or just low level poor quality of life, that they reach a point where perhaps they have their symptoms under management, but they need support to help and grow and often repurpose their life, because the life that they may have had before may not have been one that's been conducive to positive mental health. So the first and really important thing about recovery colleges is that they're there to help people find out for themselves what it is in a way that they want to live a meaningful life. And the other thing that makes them quite distinct is there's this educational paradigm. So we're set up like a college, and we run on terms rather like any school or college. And we have students, but we regard ourselves as all students. So whether you facilitate within the college as a professional or you attend as somebody who is in recovery, we're all students. And the educational ethos is overlaid with a culture of actively and proactively learning together and from each other. So we really value lived experience, and there's probably almost nobody in the college, including all the facilitators, that haven't got some lived experience of mental health challenges. So that's something that I think enables us to, if you like, redress the balance of power that a lot of people might have felt in terms of being particularly a patient, where a clinician will have been doing things to them. When they come to the recovery college, it's choice and involvement to whatever extent they choose that defines their being there. So there is, if you like, an equality that we really actively encourage. The other way that we help support people in recovery is by offering different learning pathways. So I mentioned it's educational, but it's educational in the broadest sense of the word. So we've developed a number of courses of our own, but we've taken, again, learning from the evidence of what works in other recovery colleges, and developed things like a foundational course, which is to help people really think about what recovery means, how it involves the whole person, what it actually means to them, and really importantly, if they've come through a mental health crisis or a period of being really unwell, they've been used to talking about what's wrong with them. So we really focus on what skills and strengths and innate potential they have. And I think a fourth characteristic of what we do is that we try and transform through inviting not just people who actually themselves are undergoing recovery, but other people in services to come and join workshops and courses, because other recovery colleges have found that they can transform culture within statutory and other voluntary services and just create more of a cohesion. So we see ourselves very much as there to signpost other services and to support other services. And likewise, we invite anyone from any other service to come along and sit in on workshops and be as involved as they want to be as well. So tell me if I'm going too quickly, but our sort of appeal, our population, our potential population is very broad. So we're looking at people who would, if you like, self-identify as having mental health problems or in recovery from addiction, but we're very much also a preventative service. So what we're trying to do is to draw in people who might be suffering below the radar, particularly post-COVID, with anxiety, stresses, experiences that they won't have previously had, and bring them in and try and prevent that situation, those symptoms from escalating. One of the really empowering things we do is that we offer training to volunteers, and we offer that. We're developing a pathway in peer mentor training and in other areas of volunteering, like administration, marketing. But we're very rigorous, and we will be very rigorous about how well we train our volunteers, as it's really, really important, obviously, from the point of view of their self-esteem. But it's also very important because this could be a bridge for them into employment or other voluntary work. And it's something that we would, in the not too distant future, like to have accredited. So I think I've sort of given you a really, really brief overview of what the recovery college is and hopefully what we offer and to whom. I don't know if you want me to go on to say anything more about experience to date with, you know, who's coming and what their feedback has been. Probably seen a bit of that in the report.
I was just going to say, some of this, we've had some troubles downloading the IT issues, so not everyone will have had a chance to have looked at the document. It's just been recirculated, and it's something that we can look at. So we do have a few questions at the end of it. If there's examples that you think that there's an area we've missed, please feel free to comment further. But I'll start off with the questions now, if I can answer Councillor Gibson.
Thank you, Mike. Thanks for coming along tonight, Ned. It's lovely to see you again. You did mention that you are independent rather than being run by one of the statutory services, but do you have any statutory or service level agreement responsibilities for mental health? No,
not at present, no. It's not actually a discussion I've had. So, no.
Well, thank you very much.
Sorry, I couldn't get my buttons to turn on there. Well, that was a quicker answer. But a simple no. Factual, accurate. Yeah, I mean, obviously, we're going through these questions. Some will be more relevant than others. So forgive me for that. So I will quickly scamper along to Nick for his questions, please.
Thank you. Hi, Bernadette.
Hi, Nick.
How many people are you currently supporting And how does that compare to pre-COVID?
Well, I can't compare to pre-COVID because we only opened the college in September.
Ah, okay, that's fine.
So we're really pretty fledgling. So really, okay. we've only been going for just over 2 months. I can tell you that, so most people people have to register before they can enroll on courses. We've got just shy of about 130 students registered. Now, not every, and people can choose how many or how few courses they do. So as you can imagine, some of them do a lot and some just do 1 or 2. It's entirely up to them. What we're finding is that, so I suppose if I was to say how many of those 130 are we actively supporting, probably about half will be regularly coming to workshops. You know, we're just about to launch the spring curriculum, and I'm hoping because of the different courses I'm offering that will appeal to more students. But it's quality as well, because I think what I'm interested in is, you know, the experience that students have and how much they grow from that, and how their confidence or their feeling that they can actually move on to the next stage in their recovery develops. And I would say of all the students engaged, that of those sort of 60 odd, those would be engaged in a way that is conducive to that. So in other words, there's a good relationship. I mean, relationship is foundational for the Recovery College. We do everything in small groups, and we build relationships really quickly because we do it all face to face as well.
Right, so there's no groups which are done online at all?
We do. We have, in fact, I launched quite a lot of groups online of online courses, and almost nobody wanted to do them. I think maybe because people perhaps have done enough online. They're just beginning to pick up, but one of the areas that I'd really like to develop over the next 6 to 9 months is you know, with parents with children, and also in workplaces, where I think there will be more interest in online courses. So we'll continue to offer online courses in the evening.
Yeah, I mean, I'd say that, you know, the advantage of not having to travel somewhere to do an online course, it actually does appeal to some people, so, especially if you've got kids and stuff.
Exactly. Yeah.
Okay, thank you, Mike.
I couldn't agree more with that last statement. She's got a babysitter upstairs, but I'll do. So yes, absolutely. Isabel, it's nice to see you.
Thank you. I'm Isabel Matic and I represent Harmanswater. Thank you very much for your talk. It's been really very interesting. My first question, actually, you've really answered about where your referrals come from, but are there any other places that you really need them to come forward to identify people?
Yes, absolutely. I mean, we're so embryonic and, you know, still very much I think relying on word of mouth. So even though all the statutory services and all the local voluntary services in the borough know about us, we're finding that people are coming because somebody has said to them, actually, I went and did a workshop and it was very good. I think one of the areas, I mentioned 2 areas in particular, I think we've had quite a number, they're not referrals, you quite rightly say, but we've had recommendations from places like New Hope. I've worked very closely with Gillian, and also CMHT and social prescribers and the community network. But there are still big pockets, like we're not in, for example, the job centres yet. I've tried to get into GP surgeries. I know that's really difficult. I think parent mail through our schools could be really valuable. And we would position ourselves in a way that would be, if you like, acceptable to parents. So they would know very quickly that they wouldn't have to have a diagnosed mental health problem to access the support they might feel they need from the Recovery College, and similarly workplaces. So I'm just starting to tentative steps to try and see what we can do there. But those would be the 2 main areas I would say that we really need to do some more work on. Yes. And probably tailor what we offer.
Yes. Can I ask you another question? You did actually say about helping people to get back to work, etc. Do any of them, when you've been working with them, do they come back and help you volunteer?
Yes.
As a volunteer?
So yes, you mentioned, I just jotted down a couple of case studies. So All of our volunteers, so I started off with just myself and then a paid administrator, and I've now got 5 volunteers, and they're all people who've come through the college. And it's quite interesting, because when you see people in workshops sort of week after week, it's like having a long interview with, you can really get their measure. So it's lovely to see. There's a young mother who's coming and just started to help with some administration, and she'll be great with our schools campaign. I've got a student who's now leading our gardening group up at Gillett's Hill, and a support worker in social care who's now developing the volunteer training program with us. So yes, I absolutely encourage that. It's one of the best things I think recovery colleges do, is get people to train them and then make them feel they can give back something if they want.
They're repaying you. Thank you very much. Thank you.
That's very good. We actually have seen people mention they're bringing future people to help in through the training they've received in some of the other prescription services, and it's very good to hear it's going there. And another mention for Gillett's Hill, very impressed with.
Great place.
Yes, very much. I'm looking forward to visiting. Jill, would you like to come on? I'm going to turn my video off and sound off.
Thank you, Bernadette. Really interesting. And I love Gillett's Hill, so that's great. My questions are really regarding the system. What do you think helps customers to access your service?
I think, in my very limited experience of the last few months, what helps is recommendations from their peers.
Oh.
It really, that's been very much the way I think a number of people who've been quite tentative have eventually ended up. I think the other thing that helps, I would say, is that I didn't mention, but we do offer some quite fun, creative things. So we offer singing and drama and creative writing as of next term, and arts and crafts and walking out. And it's amazing how some people choose that as their doorway to come in, to just test the water. And if they have a good experience, which from their feedback so far, thankfully they have, and they feel calm and respected and safe, it's amazing. They then start booking onto other things. So I think it's allowing people to come in through almost any one of the doors that we offer, any one of the, the courses. And I think that's what's been, that's what supports and helps them. And I think having statutory services and other voluntary organisations as well, just telling people we exist is really, really important too. So dissemination is quite a big thing that we still need to work on as well.
So you have an online presence, so they can join online, but you also have hard copies in different places, or
okay. and sort of social media. Not quite sure how effective that's been. We've got to do some assessment about what seems to be working for us. And we did the community cart in the lexicon in the summer. We're just about to do it again in December. So we really do try and keep the message out there.
So what do you think are barriers to actually people accessing? What do you see?
Oh, really? I mean, that's such a good question. I think, often it is prior experience with services and not realizing that this might be different.
Yeah.
A number of people who come in and will literally want to just tell you what a terrible experience they've had. Not necessarily all of them. And equally though, some will come in and say, I've got this amazing support worker and they've recommended you, and that would be fantastic. I think the other barrier, another important barrier, is almost the inertia factor. So one of the things I think we've got to start doing is a bit more outreach. So from next spring, we're doing some of our courses at Glenfield House, and partly because we need the facilities, because we want to be running more courses, but also because I want to bring in the residents to the Recovery College in a more virtual way, if you like. So bring the Recovery College to them. So I think a barrier for a lot of people is the physical barrier of literally getting to us. So there's a sort of psychological barrier about, well, you're just another service, aren't you? And I've done all this. I've heard that, well, I've done this and I've done that. What's different? So it's not seeing that there's anything different, but then there's also because some people really are, as you know, quite unwell. And we have, one of the issues that we identified in the report is we do have absenteeism. I'm told other recovery colleges have around the 40–50% absentee level, which at the moment we don't. We have better attendance, but we're still trying to work out strategies to sort of encourage people once they've booked to come along. So we ring them now and we say, you know, are you okay? You know, just to say if you need any extra support, we're there, you know, all of that, because I think that personal touch is really important too.
Are there any barriers with money? So you say accessing, perhaps getting transport, or do your courses cost any money, or is it?
No, it's all free. And because we're in, sorry.
Yeah, so online is okay, but I can imagine that if people actually have to catch a bus or get somewhere, it can be difficult, can't it?
It can. You'd think then that the online courses would have been really booked up, but they weren't. So we found very, very little attendance. We've cancelled more than we've run because maybe we had, you know, one student or none. So that's kind of like a work in progress. I take your point. We are in the town centre, so hopefully pretty accessible. Gillett's Hill, we will offer to take people, or we will find a way of transporting them. We don't expect.
Yeah, because that's completely out of the way, isn't it?
It is, absolutely. Nobody's actually talked about that. It's a very fair point, and maybe one that I maybe need to ask more explicitly, you know, students before they book, you know, and ask them if there's any barriers like that. So no, it's a fair point.
Thank you. Thank you very much.
Right, my video seems to have gone down. There they are. Hello, Mary. Yes.
Yeah, thank you, Mary Templeton, Councillor Mary Templeton. So if I'm understanding this right, somebody signed up for a course which would be a term, And
no, the courses run. There's two things we run. One is multi-part courses. So those will be anything from 2 parts to 6 parts. So when somebody signs up for that, we do expect them to come along for either the 6 or 4 parts or 2 parts. But they can sign up for one-off workshops, which are 2 hours in the morning or the afternoon. And they don't have to commit beyond, you know, a single workshop.
Okay, and I mean, I guess because you're so embryonic, it's really difficult to say how many of the people that have used, the clients and people who have come along, this has prevented them going on to the next stage and to escalate in their mental ill health. If it's too early to say that, really, yeah.
It is in any meaningful way. Anecdotally, I know that a number of students, maybe a handful, that I know personally have, you know, come into the college in quite a bad way and are now either volunteering with us or on very much a very steady path, it seems, in their recovery. So let's hope I can, you know, give you a lot more evidence in, you know, at the end of the year or middle of next year. But it is a bit too soon, yes. And that's going to be interesting to measure because, of course, as we're not asking people a lot of background questions, you know, I mean, we do ask them, we use the Warwick scale, wellbeing scale, and we ask that at the beginning, middle and end of the term to try and assess whether our students' wellbeing has improved. So there should be some indicators from that. Other than that, I'm not quite sure how I would measure that other than observing myself, you know, how students are doing.
Can I just ask, they come and they register and it's called a college. So do they get a certificate at the end of it? Or
they do,
oh,
yes.
They do. Okay, right.
They do. When they complete our 6-part course, they get a certificate saying they've completed it, and that's a real accomplishment. And probably as of next term, we'll be giving out certificates because we're running more multi-part courses. And then I've got to think about this, but other recovery colleges do graduation ceremonies as well. Oh, wow. I'm not quite sure how that will work, but I definitely on my radar.
Celebrate success.
Yeah, definitely.
Okay. Thank you very much. Thank you.
Anchor.
Thank you, Chair. Hi, Bernadette. Councillor Ankur Shiv Bhandari from Binfield with Warfield. So although we have touched on evidence in the previous question, and you did talk about the Warwick measurement scales, is that the key scale of measurement that you use to measure the effectiveness of your service, or are there other measures that you use to see sort of, you know, how your service is doing?
We use other measures, and at the end of each workshop or course, what we ask students to do is to give us quite a lot of feedback. They're kind of not allowed out the room before they've given it to us, because it's so important that we find out about how useful they find the sessions, whether it increases personal knowledge, did they feel able to contribute, did they feel included, safe, respected, how they rate the facilitators, whether they would recommend the college to others. So those are kind of the other measures that we would use about assessing what it is that we're offering them. Taking Mary's earlier point, I think I probably need to think of something that might actually address the issues of where they feel they have or haven't moved in their whole recovery journey and what that means to them. But I haven't formulated anything along those lines yet.
Okay, yeah, no, that's good. So when you capture this information, how do you use that to inform if any changes that are required, or how frequently do you do that?
Well, I've just done the first one. Don't forget, we're only 2 months old. And that's really made me think about a number of areas where we need to do better and where we need to focus our efforts. So one is, you know, when I looked at the demographic of who we have, we're very skewed to females. So we need to find ways to engage men. And I've learned from some of my facilitators that actually that requires a different approach for some men. We seem to have a good spread of ages, but we don't have a good spread of ethnic groups. So again, that means we need to think more about potentially outreach and being more culturally sensitive, and how we can support those in our community who aren't white Caucasian. There are a number of areas. I look at employment status as well. I think the report I've done really has informed me of quite a lot of areas where we need to really focus our efforts in the future. So I suppose in some, I will use a report that you'll see very much, and you'll see from the notes I've made where I think we need to improve.
Fantastic. So just a related question. So you've talked about, you know, sensitivities with regards to culture, etc., to get maybe more people into the fold. The ones that are already connected to you, is there something special that you do to drive their engagement further, or sort of, you know, do you see if you see any challenges with that? How do you ensure that, you know, the right level of engagement is there?
Do you mean generally with students, or do you mean?
Yes. Yeah.
Oh, so how do we kind of, once students have registered and attended, how do we keep them? Is that the question?
So I think it is a two-part thing. First is, once they have registered, how do you ensure they get the best out of it with the best level of engagement? And then the second part is, yes, you know, how do you make sure that if they need further support, they are engaged?
The first part is done by my pretty well seeing every student. So I would tend to see and meet and have a cup of tea with pretty well all the students that are now attending courses. So that level of, if you like, relationship building is really important for encouraging them, often reassuring them, and for also helping them to choose courses. So that sort of talks to the second point you asked, which is, you know, how do they know what to do? And a lot of them do come along and say, look, you know, I just don't have a clue. What would you suggest? So I sit in on every single workshop and course that there is, and will continue to do so for a number of reasons, for quality assurance, but also so I do know and I can speak to students about what I feel from what they've told me might be useful, or at least I can outline for them what we cover. It's very much personal relationship at that level. Thereafter, it's about being around after the workshops. It's those conversations I've found so far anyway, that is what makes the difference between perhaps somebody feeling a little bit tentative or coming along and feeling they're having a moment and their anxiety levels are really unmanageable. And then I'll take them aside and talk to them and have a cup of tea with them, or just reassure them. So personal engagement.
Yeah, that's great. Thank you, Bernadette. Over to you, Chairman.
Thank you. I've got one follow-up question, which I think actually is following up the last comments there. Lizzie, did you want to come in then?
Thanks, Mike. Talking about sort of accessibility and inclusivity, you've mentioned that a lot that, you have forms for people to fill out to actually book onto a course and to rate their experience on the course. If there are barriers, whether it be dyslexia or anxiety or executive function to do with neurodiversity, is there the support in filling those out so that that doesn't in itself become a barrier? And how do you go about doing that?
Yeah, and I think it's really a work in progress. So we're running, we had some inquiries from a couple of students who are profoundly deaf, and so what we've done is, and I think it's happening in the next week, we're running a special workshop on the subject that they were interested in with their supporters, purely so that, and with signing, so that they can understand and they can get something out of it. And I suppose that's kind of like a pilot. So we'll see how that goes. And if they want to do something else, then we'll run that. We're running that from the college. The second area, literacy, I've actually got somebody at the moment who I sit with, and we most of what we do is quite visual, so it's not a lot to do with words. It's more to do with listening to a facilitator, and usually they're showing quite explicit visuals that are drawings. But when we come to doing something that's written, we'll do it as a partnership, so I'll sit and do it with him. And in terms of anxiety and that I think that's just something we come across all the time, and it's highlights for me how important it is that all of our volunteers have those important empathetic skills and really do understand, which is why the training that we're trying to put in place, needs to be good, because we need people who really are going to actually help people rather than inadvertently making them, feel worse. But I think that support is a type of support that we will always have to and should always offer at the college. But it tends to be one-on-one at the moment. Does that answer your question?
Yes, thank you very much. I had to find the mute button.
Oh, sorry.
Bernadette, thank you very much for that. We've got a couple of minutes left. Is there anything else that you think that we should know about access to and engagement in your service? You have covered it fairly, but I want to give you the opportunity if there's anything else you want to add in the next couple of minutes to the panel.
I mean, thank you so much again for the opportunity. I think the only thing is, because we're so new and because we rely so much on people telling others and telling, particularly people who they think might benefit from the service, even if they're not sure, just actually telling them about stepping stones and suggesting they come along and have a cup of tea. The doors, we've got quite a cozy area of our own in the involved building. We've got a chill out room where, which is quite small, where people can feel safe. So I think it's just, reassuring people that just to have a conversation. They're not committing to anything. So, yeah.
That's excellent. I can't thank you enough for coming along. I knew it would be interesting when we previously met, and I think that this has been very useful. And I do take on the point.
Thank you.
Generally take on the point that we can distribute it we can recommend it's distributed amongst our people that use it, so that
yes, please do
get the word out. That's what I'm trying to say.
Thanks. That would be amazing. Yeah, thank you.
Thank you very much, Bernadette.
Okay. And thank you so much, all of you, for your time and your questions. Really, really interesting. I've got extra things to do now.
And you're thanking us for it. Excellent.
Okay, so I'll say good night. Bye.
Thank you. Good night.
Thank you very much indeed.
Bye.
Jen,
Thank you.
we are just briefly before we bring in Kate, questions, because we haven't done a question for Mary on this. Have we lost someone then? Yeah, well, that went off. Right. Jen?
Chair, I've just rejoined from a different device.
Yes,
right,
I saw that.
Right, so
well, I'll take whatever questions are left. If you've got any left or not, as the case may be, I can listen.
Yeah. Can you remind us, Mike, which ones we were doing? I can't remember now.
Yeah, I will do. I think that's. Let me just go up the list.
Jill is doing 1 and 2.
Yeah, I've got 1 and 2 written down.
Nick is doing 3 and 4. Isabel 5 and 6. Lizzie 7 and 8. And Mike, you were doing 9 and 10. So if anybody would like to offer one, to Mary.
Mary, what are the barriers to accessing effective care?
What are the barriers to what?
Accessing.
Okay, yeah, all right.
Accessing effective care. I've lost 10 because it's on the next piece of paper. Hold on a second. What was 10? Isn't that the sort of catch-all one?
Yes. Is there anything else?
Is there anything else? I'll do the anything else because it's a good one for me. So, Mary, if you're happy with that.
Yeah, that's fine. Who do I come after? Oh, you can tell me anyway. Don't worry.
That's after Lizzie.
Coming after who's on 8?
After Lizzie.
Yeah, so you're after Lizzie, and then I will wrap up. So, if you can,
I'll invite Dr. Katie Simpson in.
We can confirm the order of people or not.
Oh yes, sorry.
Should I pop it in the chat to everyone?
Hang on a second.
Yeah, it'd be useful.
Okay, I'll do that. I'm just going to invite Katie in.
Have you got that, Nick?
Yeah, I can see it.
Cheers. Hello, Katie, are you there? Can you hear us? Just making sure the IT works.
Oh, I have my video on. Can you see me?
Not yet.
Right. Okay. How do I do that? I've not been on Zoom for a long time because I do a lot of Teams, but oh, here we go. Yeah.
Oh, yes, there you are.
Hi there.
Let's make a job. Right. So this is just to say this is a reminder that this is a public meeting and it is being broadcast. They won't come onto this because people can watch through YouTube, so you won't see additional people on the scene. If anybody forgets to unmute themselves, Jen might mute you because of background noise or for whatever reason. I'd like to welcome Dr. Katie Simpson, who is the NHS Frimley CCG clinical lead and on mental health. If I got your title right there.
Yeah. Yes. Thank you. Yeah.
I do get some tongue-tied on that. So basically what we're hoping for is an overview for you for about 10 minutes, and then I'll open it up to the panel to start asking you questions, and I'll mute myself and turn my video off while you're talking. So if that's okay, without any further ado, thank you very much for joining us.
That's great. Thank you very much. And yeah, just to clarify, I'm a GP. I'm working in Windsor and I have previously worked in Bracknell and Ascot. I know the area very well. I meet regularly with the Bracknell GPs, so your PCN clinical directors. Had a meeting with them last week, in fact, looking at kind of improving delivery of the SMI, so that's the severe mental illness health checks, and spend a lot of time networking and linking in with GPs across East Berkshire. As I say, last week I was specifically working with the Bracknell PCN CDs. That is the big part of my role, really. It's providing that sort of link and liaison between sort of primary and secondary care, representing primary care, and making sure that the mental health system works, for patients as well as for our primary care colleagues. So I'm involved with children and young people, although I believe you've got Susanna, Jordan and Karen Cridland coming to speak to you about children and young people, so I won't spend too much time talking about them. I also work in adult mental health and used to work for the Strategic Health Authority, so I was involved with setting up IAP, so our talking therapist service, back, kind of 10 years ago now. Also sort of very involved with the delivery of interventions for severe mental illness and also dementia as well, working as clinical lead for dementia across the area. So it's quite a sort of broad brief, but as I say, I really see myself as the conduit between sort of primary care and secondary care. I was asked to say things that are working really well, and I think one thing that we have developed really well is a system of training for primary care in mental health. So I work closely with Bracknell GP, Dr. Chow Kincaid from Gainsborough Practice, who's our educational lead. and he allows me to run a mental health protected learning time annually. So all the Bracknell practices are represented at that. They have the out of hours covering them. And this year, back in July, we did suicide prevention training, anxiety in children, eating disorders in children, improving access to talking therapies, and gave the GPs an overview of all the current mental health developments, both in the adult and the child world. Your Bracknell PCNCDs also joined me on a very successful clinical interface committee, which brings together primary and secondary care colleagues in the mental health field, where we look at specific topics. So in the last 6 months, we've looked at ADHD prescribing, we've looked at dementia prescribing, antipsychotic prescribing, and this month we'll be looking at diabetes care and the importance of working together for the physical and mental health benefits of our patients with diabetes. The other thing that I think has been really positive is the responsive and innovative service that our talking therapies service provide. So through the pandemic, I think you heard from Nadia and Aidan last week, so there may be some duplication, but they really did flex their offer, and they went totally digital. They now offer something called Silver Cloud to anybody on their waiting list, which is an online CBT program, which is a treatment package in its own right. And they've worked very closely with myself and other primary care colleagues, and have attended the clinical interface committee to try and get things right. The other thing that you may not be aware of is that because of the longer times for the Berkshire Trauma Service, they have actually flexed their approach of talking therapies, and they're now offering not just treatment for anxiety, depression, phobia, and single incident PTSD, but they're also offering an extended trauma pathway as well to sort of reduce the weight. And the other thing that I think is successful is that we have a very collaborative mental health trust who work really well with primary care and also with our commissioners as well, as evidenced by the clinical interface committee and also our mental health programme board, where we meet on a 6-weekly basis to look at performance and services across the patch. So I think that's the success. I also just wanted to share some training that we've delivered to all GPs across East Berkshire, which is called the LINK programme, which we're really proud of. We've got some funding to train up a cohort of GPs who are particularly interested in children and young people's mental health. And they are getting bespoke training on every aspect of children and young people's mental health, and then going back and taking that training to their practices so that they understand the complex world of children and young people's mental health and how best to help parents, children and carers navigate and support them on their journey through mental health services and pre and post as well. So I think that has been a particular success as well. I know that I think you'll have a lot of questions, and I didn't prepare a presentation because...
No, that's absolutely fine. I just wanted to give you a chance to give a longer introduction. It wasn't really expecting a presentation from you, but place setting where you are and who you are, what you did.
And I think Nadia and Aidan did. I have seen their presentation because they came to you last week, and unfortunately, because I'm duty doctor on Monday, so I couldn't attend last Monday's meeting, which is I think why you've got me here today. But I've seen their presentation, so I think that's given quite a comprehensive overview of things like key performance indicators and waiting times and the like.
Well, we won't keep you too long tonight. We're very grateful for you coming along, and if I can hand over to Jill to ask the first question. Thank you.
Thank you.
Thank you. Thank you, Katie. Lovely to meet you. Councillor Birch, I represent Hanworth. My first question is into the system. How do people actually access the system?
Okay, so all the services offer a self-referral route in. That might not be that well known. And actually, I checked on the Bracknell Forest Council website and I saw it had a reasonably comprehensive offer of what was available, but it only had the phone number for talking therapies, and it didn't have the link to their website, which has a huge amount of self-help and resources, and also has the kind of online referral form. So I think, that would be a great addition to your council website, actually, if possible. So all of the services offer self-referral. Still, a lot of people do come through primary care, and that is why there's training and supporting our primary care colleagues in pathways and managing sort of these important mental health conditions is really key. But what's not widely known is that many other professionals can refer as well. So the Mental Health Trust will take referrals from police officers, social workers, allied health staff like paramedics or clinical pharmacists. And actually they prefer referrals for children to come from schools, because obviously the GP has a 10-minute consultation or maybe a 20-minute consultation with a child and their parent. But actually the schools know about academic performance, social functioning, and actually the CAMS referrals are encouraged to come through schools. So there's a wide variety in, but I don't think it's always well understood. And I think a lot of people still feel they have to come through the GP, but we would certainly encourage self-referral. Yeah.
Thank you. I mean, you've actually given us a really good idea for one of the recommendations, to look at the website and to make sure that that is populated correctly. So thank you for that.
Thank you.
So who triages referrals? Do they get a sort of triage system? And is there sort of this?
Yeah, we worked really hard on this because we understood it was confusing. GPs and self-referrers were coming into sort of different access points. So last year, and in fact just pre-pandemic, we worked on something called the Gateway. And the Gateway now is the single access point to mental health services. And part of that involved redesigning the mental health referral form, which is an intuitive form that talks the referrer through how to make a referral and what all the different options are. And basically, once a referral goes into the Gateway, the administrative staff have clinical staff working with them, and they will have, if it's very obvious, if the GP said this patient is for talking therapies and the clinical details match with that pattern, then they will get allocated to talking therapies. If the situation is more complicated, or maybe they need more intensive treatment, then likely they will go to the referral management meeting, which happens regularly, where referrals are discussed and triaged. And then there's a route in for the new mixed service, which I think you've probably heard of, which is part of our community mental health transformation, which is putting kind of community psychiatric nurses, psychiatrists, and the mental health team into primary care. And those referrals, the GP can actually sort of direct that referral straight into the system and say they've discussed it with the mixed team and that it doesn't need to go through the referral triage process, so that we can streamline patients getting the service they need straight away. So it's the Gateway does the triaging, but the GP has the can influence that process so that patients can go to the right place quickly, rather than having to necessarily have a comprehensive triage. But if there's any confusion or complication, then they would have what's called a Gateway assessment, which would be a senior member of staff there, usually a psychologist, assessing the patient.
So are there sort of timescales? Do you have timescales against some of these?
Yeah. So with an urgent referral, the Gateway, and that's something that the GP would need to phone through, or if it's another professional or a patient, obviously they would make the judgment call on if this is a crisis referral, then they will action it within an hour. And then if it's deemed to be, and that's 100%, I've heard from our divisional director, Susanna Yeoman, that they're reaching 100% on that. If when the Gateway assess the patient and they agree it's a crisis, then the referral gets passed on to the crisis response team, and they operate a 3-hour wait so that the patient can be seen within 4 hours, which is what we're looking to. So they manage crisis referrals really well. Talking therapies, the current wait for what's called a step 2 treatment, which is the first step in the pathway of treatment, is just under 4 weeks. And then if they need a step 3 treatment, which is more one-to-one cognitive behaviour therapy or counselling and tends to be sort of longer term, sort of 10 to 12 weeks, then the current wait for that is between 10 to 12 weeks. And then a routine Gateway assessment. So someone who's being referred for the Gateway where it's not clear, then the current wait for that is 11 weeks. So we've got very short access into talking therapies, and very short access to crisis, but an 11-week wait for routine, care otherwise.
Thank you very much. That's really clear. Thank you.
Thank you.
Nick, you would. Sorry, my video.
I'm Nick Allen. I'm a councillor for College Town. In fact, part of my question has been answered already, because my first question was what are the treatment support options? I think you've covered some of that already.
I could give you a bit more detail, actually, if that's all right, Councillor Allen. So I've mentioned about the gateway and talking therapies. As part of that, we also commissioned just pre-pandemic, but the service launched in the pandemic, something called the Wellbeing Service, which sits underneath talking therapies. And so they will offer, we were finding, well, before we set the gateway up, there's a lot of referrals were coming in that didn't necessarily meet the threshold for secondary care mental health, but they had problems or issues that wouldn't necessarily be met by talking therapies, for example, finance, housing, perhaps sort of substance abuse, issues. And so the Wellbeing Service was commissioned in early 2020 and recruited during the pandemic. So it's been quite a challenge. And they are clinically supervised by talking therapies, but they do offer a sort of what's called a lighter touch. So it's not a psychological therapy, it's more of a supportive therapy. And that's the Wellbeing Service. Now, obviously, for patients who have more severe and enduring mental health problems, they'll go usually to the community mental health team. And part of that is secondary care psychology, which it sits, above talking therapies, but, similar offer, but different types of patients with more serious mental health problems. And in that secondary care system, we also have a personality disorder pathway as well. So usually that diagnosis would be made on a gateway assessment or by a GP suggesting perhaps this patient may have a personality disorder. And then the pathway is either that they go through this new mix service, which is the new community mental health service in primary care, which Bracknell's very well covered. Bracknell actually had all areas covered. Slough and Windsor only had one mixed service for each of those PCNs, but Bracknell has had a full mixed service since the since it launched last year. So I think, and then within secondary care, they have something called the Impact Service, which is a sort of 18-month course of long-term psychological therapy to treat personality disorder. There's also the trauma service that I've mentioned that has quite long waits. It is a nationally renowned service, and we have people being referred in out of area because it is a highly renowned service run by Deborah Lee, who's very esteemed in the trauma world. And as I say, talking therapy is working with the trauma service. And then, of course, we have the voluntary sector, which, we jointly commission Youthline with you. And of course, you have your Sandhurst counselling. And also we've expanded our offer for Friends in Need, which is run by Buckinghamshire Mind. And they provide befriending and peer support for people with either loneliness, anxiety, or, social isolation or mental health problems. And that's been really successful, actually. We recognise that treating mental health problems isn't just all about maybe medication or psychological therapy, but actually having a tribe, having a group of friends, people that can support you on the journey is really important. And that's been a real success story, I think.
Oh, that's excellent. Very good answer. So you did some of this. I don't know whether you've mentioned all of them, but you said the question is, how long does it take for treatment support to start? Now, some of them you said, can almost within hours, but and some were, I think your average or your default was 11 weeks, and somewhere and somewhere in between, aren't they?
They're all very different. So the target for the mix, which is our community mental health transformation, is 4 weeks. So that's a national target that we've been set. Now, I've just checked today. And Bracknell and District, they're still reporting for the 2 Bracknell PCNs rather than the 3 at the moment. So Bracknell and District are currently running at 27 days wait, and Bracknell Health Triangle is 21 days. And the reason for that is there've been a lot of staff turnover. It's a new service and it's finding its feet. So at the moment, they're recruiting 2 new nursing staff. So it's running slightly over the target. We would, it's within the 4 weeks, but we would like it to be 2 weeks. We'd like it to be sort of, more responsive. And the trauma service, I alluded to the fact it had long waiting times. That has a 1-year wait, which has come down. It used to be 2 years, but since talking therapies have taken over some of those patients, the waits come down. And at the moment, we're doing a review on the sort of trauma pathway to look at all strands of it. So what talking therapies can offer, what the secondary care psychology service can offer in CMHT, and what the trauma service can offer, and obviously increased investment as well. Because we recognise that trauma has been a big issue for many people in the pandemic. Yeah.
Thank you. That's very useful, Mike.
Yeah, it was very good to hear you talking about the Friends Service. We've actually had a speaker earlier talking about that, and
partly the Friends in Need.
Yes, and
brilliant. Yeah.
So partly what we hope to promote through this review is to actually make sure people are talking to each other. So it's so nice to actually hear that it's actually happening and people are recognizing what's going on. Isabel, you're next.
Thank you very much. Thank you very much, Katie. It's really been very interesting. I'm Isabel Matic and I'm a counsellor for Harmanswater.
Okay.
So thank you very much. Following on from what Nick asked, how successful has the treatment support been, including the relevant KPIs?
Okay, so talking therapy is very successful. So the service is quite heavily performance managed in terms of its outcomes, and the service in Bracknell is certainly hitting its targets, both in terms of waiting times. So they have to have 75% of patients seen within 6 weeks, 95% within 18 weeks, and they're hitting that. They're in the 90% for 6 weeks, actually. And the recovery rates are well above target as well. So, certainly, we should be rightly proud of our talking therapist service. An interesting thing that we're finding is that the talking therapies aren't quite hitting their access target. So there's not enough people going through the service, although they're not quiet, because those that are going in are more complex and have more challenging issues, so are needing longer treatments. But they haven't quite got the number of referrals in, and that's something we're sort of working to address. And that's why I was suggesting promoting it on the Bracknell Forest website would be good to sort of get more sort of traffic through. So yeah, as I say, we do look at talking therapies very closely. In terms of the mixed service, that reporting is just they are due to report at the end of Q3, so we will have some data, but I can't give you that at the moment. And as I say, I think you had that shared. I think that you had the performance dashboard last Monday, didn't you, from Nadia and Aidan? So hopefully you've seen the other service areas that we report on.
That's good. It's nice to hear that, where there are some inadequacies, you've actually got them on the radar. So I think that's really good. Can you say, following, is about the follow-up to check whether the next stages have been successful? How does this work? Is it successful, or could it be improved, or?
Okay, so I don't know if you've heard of something called the step care pathway. Has anyone mentioned that yet? No. So basically our mental health services follow something called the step care pathway, which is matching the least invasive intervention to the patient. So if you imagine sort of like a pyramid, the majority of people will have sort of step 1 and step 2. So step 1 would be primary care, working with counselling organisations, promoting exercise, well-being, good diet, meditation, mindfulness, and sort of sleep advice, and those sorts of behavioural activation. Yeah. Step 2 would be where our talking therapists offer would start. So once a patient's been referred into talking therapies, step 2 is what's called a low intensity intervention. So that is usually delivered online. They might follow an online computer program of cognitive behaviour therapy. They might do a workshop. It might be phone therapy. And then at the end of that, if the patient hasn't recovered, they would then be stepped up to the step 3 intervention. And it's all about being cost effective, because if everyone had a step 3 intervention, which is the one-to-one extended CBT or counselling, the service would be overwhelmed. But actually the recovery rates for the step 2 interventions are higher than the step 3. But as I say, if the patient hasn't recovered on the step 2, then the step 2 therapist would step them up to step 3. If they've gone to step 3, which is the sort of top level of talking therapies, and they haven't recovered, then they would be referred onto the gateway for consideration of where they go next. So that's the beauty of the step care model. People, follow up and sort of get matched to the level of intervention that suits them. But if there isn't an intervention available within talking therapies or primary care, then it would be stepped up to secondary care, which is our CMHT and gateway.
So it's really very comprehensive. Thank you very much indeed. Thank you.
Thank you very much for that as well. Lizzie.
Thank you. Thanks, Katie. Earlier this evening, we heard how sometimes inertia due to mental health issues such as depression was preventing people accessing some of the other services we've talked to this evening. If a GP has suggested a patient self-refers to talking therapies, for example, is there any way of checking whether this has been successful, or whether due to inertia the patient hasn't managed to take that step to get themselves into the system in the first place? And if so, how would you refer to get residents back into the system?
Okay, that's a really good question, and it's something that I've been saying a lot to GPs across the system, and we shared this at our protected learning time, that actually there isn't any way to track whether if a GP has signposted, and we did trial this with talking therapies. We gave little cards out for GPs when GPs were doing more face-to-face consultations, little cards that they could ring up and quote a reference number, but it didn't really work. But what I say to all my colleagues is please do a referral, because you're quite right. The motivation, which can be very evident in the consulting room, can actually disappear, and the confidence to actually pick the phone up and make that phone call. So I would always make a referral. It takes a couple of minutes to do it on the referral management process that we use. We use a system called DXS, and so I'm asking all my colleagues to actually make the referral. Rather than signposting, because we do lose quite a lot of people, I think, that way. Yeah, I think you've absolutely hit the nail on the head.
It's really good to hear that GPs are encouraged to do that. Thank you very much.
Mary.
Yeah, thank you very much. I'm Mary Templeton. I'm a counsellor for Great Horners North. My question really is that you've shown us lots and lots of ways in which people can access care or well-being strategies. So what are the barriers to this? Can you name some? I mean, we've already said that signposting doesn't work. You said that just now. So,
I don't think it works for everybody. It can be successful, but I do think we lose people
that don't follow that up. And so what are other barriers for people for not accessing this care?
Okay, I think there is a barrier with primary care at the moment, because we've looked at the data across our Bracknell practices. And if we compare activity, in GPs managing mental health problems from April 2019 to April 2021, there's been a 20% increase with no increase in primary care numbers. So in fact, a slight reduction in GP numbers. So there's been obviously quite a significant pressure on primary care, for all kind of conditions, but sort of, as I say, mental health, there's been a sort of 20% increase. I think it's that, the lack of increase in numbers. Obviously, we were hoping for more GPs, and unfortunately they're not materialising. So the numbers haven't grown by 20%. So there's more of a strain on primary care as a result. I think a lot of people aren't aware of e-consult, which, so if people aren't technologically enabled, then, all GPs in the Bracknell area will do something called e-consult, where a patient can fill in an online form and request a response back from their GP, which is a nice way of accessing care if you don't want to sit on the phone and for hours in the morning. But if you're not digitally enabled, then of course, or you're not aware of that, then that could certainly be a barrier to care. And then I think there's because of this fast changing landscape, I've mentioned about this new mixed service that maybe many of our residents don't know about. We also have these R's roles, which are additional roles and responsibilities. So they, the primary care networks are employing people to help with GP workload. So we have paramedics and clinical pharmacists and physiotherapists. And Bracknell PCNs have been in the first wave to actually employ mental health R's staff who will triage referrals in primary care, and there'll be trained mental health professionals working side by side. But there's so many, so much kind of movement, and it's and in the children's landscape as well, which I think you'll hear more about next time. There's so many new services. I think it's really hard for people to keep abreast, you know, of everything that's out there. You know, I've mentioned there's some inadequacies in the local website, and certainly I don't think there's one site in this area where all of the mental health services are sort of listed and where you can easily access all of that information. So I think certainly there are some barriers. We do have kind of translators, and all of the talking therapies materials are in the majority of the Southeast Asian languages and the Eastern European languages, and they do have a translation service as well. But clearly, you know, translation is, you know, doesn't work as well as speaking in your sort of mother tongue. So I think that can be a bit of a barrier as well.
Can I also ask, supposing somebody, they go in and they go through their doctor and they get a phone call and they get a sort of medical checked with all the dimension things up, go back from the January backwards and all the rest of it, and that they've given the test to see it, and they seem to pass that at that point. Is there any follow-up later, say a few months later, to see if there's been deterioration or anything else like that?
So not usually formal follow-up. In fact, that's something we've been discussing as part of dementia reviews across the area, because some services, for example, in Sheffield, they do, when you've been diagnosed with mild cognitive impairment, where you may have some slight memory problems, but you don't hit the threshold for the diagnosis of dementia, they will follow patients up. But I think nationally there hasn't been a steer on that, and in Berkshire, the onus at the moment is on the patient carer and or the GP to sort of see the patient regularly. And usually this kind of cohort of patients will have other long-term conditions, perhaps high blood pressure, you know, maybe diabetes, maybe heart problems, where they are in regular review by the GP. So ordinary, in answer to your question, there's no formal review process, and mild cognitive impairment isn't reviewed on an annual basis like it is in other areas. So yeah, it's really down to the sort of patient carer and GP to repeat those tests. Yeah.
Okay, thank you.
Thank you.
Just coming to the end now of our questions. One thing, I think you have touched on the area, but perhaps you'd like to bring it out more. What do you think works well in the systems you described for the referrals? Perhaps cases around, is there anything else that you think we should know that we haven't touched in our questions that you'd like to bring to the forefront to the panel? And I do, the thing about the web, it seems like a small detail, but that sort of thing is so crucial.
Which thing about what, sorry?
Your reference to the website only going.
Oh, the website, yeah.
And it seems like a minor thing, and there's lots of people that look at this sort of thing and it hasn't been done. So that's going to be a recommendation. Thank you. Sorry, but anything else you want to say to the panel, and anything about things that are working particularly well in your view?
Yeah, I mean, I think we've been really fortunate. Frimley as a health system has, you know, got in there quite quickly with innovation. So we were one of the first areas to expand our talking therapy service into long-term conditions. So we have psychologists that are trained in helping people manage their diabetes, their chronic obstructive pulmonary disease, and their heart disease. We were, as I say, one of the pilot sites for this community mental health transformation. And we were in wave 2 of the children and young people's mental health transformation with our mental health support teams in schools and getting help teams as well. So I think, you know, we are a sort of health system that's known for sort of innovation and sort of being early adopters. So I think that's really positive. And I think that has, you know, led to sort of huge benefits in terms of, you know, the health of, and as I say, in particular Bracknell, because the mixed service has covered the whole of Bracknell from the start, whereas the coverage has been patchy across the other areas. I think I've probably detailed, you know, everything else. I think you've got a very good dementia advisory service. I'm sure Karen White will be coming to speak to you about, you know, dementia services. But I think, you know, the work that she does is brilliant. You know, looking after those patients and carers with dementia. I think one thing that I know that AAA weren't able to, you know, because of the pandemic, the way their services were structured, they weren't able to fully support everyone as well as perhaps other kind of voluntary sector support agencies had, for example, Alzheimer's dementia support in Slough and Windsor and Maidenhead. So I think that's an area that could sort of potentially be looked at. But yeah, as I said, be very happy to work with you on looking at kind of the website, looking at getting further information out there, and perhaps co-designing something together.
Absolutely, that's excellent. Usually at this point, I'll ask the council if they've got any follow-up questions. I've got one indication. We're near the end of time. Were you happy to take one more question?
Of course, yeah.
Councillor Gibson, and then Isabel.
Thank you, Mike. Really good to hear that you've expanded into specialists leaning with chronic illnesses, etc. I've been reading a lot recently about how a lot of autistic women are often misdiagnosed with mental health conditions before getting an autism diagnosis. Yeah. So are your mental health workers aware of autism, how it presents, particularly in women, and also strategies for working with autistic people that may differ from their neurotypical counterparts?
Sure, no, that's really good question, Sarah, and you're quite right. Very often, women with autism may be misdiagnosed with personality disorder, for example, and it's something we are very, very aware of. Now, I think you'll be hearing about the big investment into children's neurodiversity services at the next meeting, but we are working at the moment with the adult neurodiversity services in Berkshire Healthcare and looking at increased investment. So we've already put some limited investment in, but we're looking at kind of transforming and putting significant investment into reducing wait times for the neurodiversity pathway. So that's adults with suspected autism or adults with suspected ADHD. And, that's something that, I feel really strongly about, that we shouldn't have these very long waits that are there at the moment. We have some real experts within that field, and part of the service that we commissioned from them was to train up other areas in understanding autism and being able to flex the approach. So they have trained up talking therapy staff in, approaches, how the neurodiverse brain would work and how to flex their offer for talking therapies. And we've talked about it a lot in MIX, actually, because although MIX is not a diagnostic service for autism, but of course we are going to get people coming through who maybe have got some personality difficulties, who maybe are, autistic as well. And it's very much linking them up with the adult autism service. So yes, there's quite a lot of work afoot at the moment, and it's a really, really important area, something close to my heart. Yeah,
that's really positive to hear. Thank you.
Thank you for that question. Last hand I'm going to allow, because we must let Katie get away. Isabel.
Just a comment. I'm delighted to hear you mention AAA, because I'm one of the founder members. We started AAA because there was no one helping those with early onset dementias, which is what my husband had. And I know that they are very upset. I know a number of the people who run it now have actually been ill. So I know they're hoping to get back on track, and I am in contact with them. But they do provide, as you know, a very valuable service. And thank you.
No, they do. And I used to, because when I worked in Ascot and Bracknell, I was, one of my patients was also one of the, co-founders as well. So I used to come and do sort of regular talks. And we are about to start the East Berkshire Dementia Forum actually wound down due to COVID, but we're about to relaunch it in the new year, and we'd really like to have AAA around the table. So it would be fantastic if we could, we've got Alzheimer's dementia support, but it'd be great to work together. Yeah.
I'll have a word with them tomorrow.
Thank you. Thanks very much.
Thank you very much for that. I presume Lizzie's hand up is from the previous question. Thank you, Katie. Then we will be making our recommendations. Hopefully, we'll link up with Jill to Jen to look at those recommendations, especially about the website. And we should be producing our recommendations to go to Commission about 8th of February. So we'll be able to give you the draft report then.
Lovely, thank you.
But it just
Thanks
takes me to say thank you on behalf of the rest of the panel members. Thank you for your time and coming out. It's been really useful.
Great to meet you all. Thanks very much for inviting
Thank you
me.
very much for your
Thank
time.
you. Thanks.
Thank you.
Bye-bye.
Thank you.
Bye.
Good night.
Good night.